thank you very much. We're going to round up the Andrology Day with a session looking at medical legal issues, and we've got a great number of 4 speakers that are going to be doing various aspects of what's topical at the moment in our specialty, where we're fairly prone to medical legal issues. So myself and Maj Shabir will be chairing the session. I'll let Maj introduce our first speaker.
Thanks. So we want to try to make the sessions as interactive as possible, so if you do have questions, do bring them forward. We're going to start off with Vaibhav giving a talk about chaperones and andrology, and he's from Worcester Hospital. So Vaibhav, do you want to come join us?
Thank you very much indeed, Mr. Chairman. Ladies and gentlemen, it's a real pleasure to be here today and have the opportunity to discuss the issue of chaperones and andrology, and not just andrology, but urology as a whole, really. It's an interesting area, but I can't pretend it's particularly highbrow. It's not prostate cancer, this. It's not particularly highbrow. It's extremely unlikely that I'm going to say anything particularly controversial. I can promise you that I certainly did not search through 1 million papers before I came here today. There are no raging controversies. It's unlikely that one of you is going to want to come out of your chair up here and pull me down off this stage. Never speak too early. It might happen. I can see a few faces that might want to, but it's pretty unlikely. And I can absolutely assure you that during the duration of this talk, there will be no mention of MRI. Not before, not during, not after. So why bother? Why bother taking up a session talking about the issue of chaperones? This is why. I think you'll all agree this is pretty much the stuff nightmares are made of. The gentleman to the left of your picture is a consultant gynecologist. I have put this up with his permission. I spoke to him only a few weeks ago. His name is Angus Thompson. He works in our trust, the trust that I'm currently training in. The lady that you see in the picture there is one of his old patients. This is an incident that took place about 4 years ago. Essentially, this lady came to see Mr. Thompson privately, and following a fairly routine gynecological complaint, he took a history, examined the patient, which included an abdominal examination and also a speculum examination. This was all done in the presence of a chaperone. He actually dealt with this case rather interestingly. He saw the patient and sent her away for some investigations, and upon her second visit decided that due to her slightly strange affect and also what he described as inappropriate behaviour, he didn't really want to see her again. So he wrote a letter to the patient and also to the medical director informing him that she had behaved somewhat inappropriately and he didn't wish to see her again. About 9 months later, he received a letter, and the letter stated from the patient that she felt she'd been sexually assaulted by him. He, according to her, had given her a leg buckling orgasm. He was quite surprised by this, I think rightly so. And given the fact that there was a chaperone there, this wasn't going to pose too much of a problem. It's a lot of paperwork, it's distressing, but he could quite easily prove that this was not the case, and clearly the patient was wrong. The inevitable happened. The private hospital investigated the case at length, and in doing so quickly came to the conclusion that Mr. Thompson had done nothing wrong. It was then investigated by the trust, the Worcestershire Acute Trust, who also came to the same conclusion. They pored over the notes, and finally, the one that we all worry about, the GMC review took place, and they also pored over the notes, looked at all the available evidence, including the evidence that came from the chaperone, and decided there was really no case to answer. Good, all done, dusted, and clearly we don't need to do much else with this. Not quite. It's not quite how it works. And it was interesting, whilst I was looking through this material, that I found it is fairly easy for a patient to raise a civil case against a doctor. In fact, all it really takes is a claim form £500 to £1,000 and to find somebody that's willing to represent you. The judge in this case, despite the GMC, the private hospital, and the trust dismissing the case, felt that this was an important issue. It needed to be addressed carefully, and therefore upheld her right to have a civil hearing. Claimants don't actually need to establish the validity of their allegation in a robust manner prior to having a hearing. And very interestingly, the claimant maintains her anonymity, whilst of course the surgeon, Mr. Thompson in this case, does not. And the inevitable follows, the sensationalist headlines. So we've gone from a case which really, in a way, had no legs, to a case which is now across the media. There are headlines such as "Gynecologist gave me 2 orgasms in 2 minutes." She's already claimed that he gave her a leg buckling orgasm. And there's also the issue of abuse. In the end, within a week of this case being heard, the claimant decided to drop the allegation. Why? Because actually several other doctors came out of the woodwork and gave evidence to the effect that she had done this previously. There was previous history of such claims. She took the bill for the case, and all in all, from beginning to end, this was a 3-year ordeal. This was an extract from the newspaper, the local newspaper. Standing on the steps of Worcester County Court with his GP wife, Lucy, Mr. Thompson collapsed in tears as he described the relief of being able to return to work with his professional reputation intact. And there is some doubt over that, because once this sort of thing gets in the media, it's a hard and long road back to where you were before any of this happened. He claimed a 3-year ordeal ending with a week in court had been unspeakably stressful. And speaking to him only a couple of weeks on the phone, that's probably an understatement. I think we're equally vulnerable, actually. We regularly perform examinations of an intimate nature. We have conversations of an intimate nature. We live in a culture where complaints are rising. I know Mr. Summerton's going to expand on that further. 10% or so of the complaints that we now receive are related to the attitude of staff. There's plenty of guidance. There is very little excuse for being caught out. The GMC have got very clear guidances on what's expected of each and every one of us. We should all be making a chaperone available to all of our patients all the time. Ideally, apparently, this should take place at the time of booking. I think that's almost unheard of. I certainly haven't seen it. If the patient decides they do not want to chaperone, you must document in the notes that the offer was made in the first place. Chaperone training. How many of your chaperones are trained adequately to do the role? They must understand what's meant by the term. They should understand what is meant by an intimate examination. And very importantly, they should also understand what the rights of the doctor and the patient are. In doing so, and perhaps most importantly, they should really understand what the policy and the mechanisms within your trust are to raise the matter higher up. So I think around 12 months ago now, we concluded a brief survey. We surveyed all UK urologists through BAUS membership. That included trainees, consultants, trust-grade doctors, and it was a very simple 12-question SurveyMonkey questionnaire. We had a 26% response rate, and encouragingly, 261 consultants replied. And we found some interesting things. Almost 40% of those that replied were not aware of any GMC guidance on the use of chaperones. 80% or so felt that a chaperone was necessary during intimate examination. It does beg the question what the other fifth felt. Patients of the same gender, really interesting area. I think it's reasonable to say that certainly during my training so far, you do have a more lax attitude for patients of the same gender, and I'll come on to why that might be later on, but we are all human, and inevitably we make presumptions. Documentation, this is a really interesting one, because in Angus Thompson's case, the documentation and the chaperone testimony really did save him. 40% of urologists document the use of a chaperone in clinical notes. Actually, I was surprised by that, pleasantly surprised. I thought that was higher than what we might hear of. So what have we learned? Well, we've learned that there's a tremendous variation in practice amongst urologists in the UK. I suspect that's representative of urologists everywhere. There's an "it won't happen to me" attitude, or one can certainly assume that that's the attitude, because the results can't be explained in any other way, really. We make presumptions. We make presumptions about people's sexual orientation. Oh, it's a bloke, it's okay, I'm a bloke, it will be fine. We make presumptions about their age and how they perceive their examination. And we also make presumptions about their vulnerability, whether that be cultural or, again, as I say, age, or what they actually understand about why they're there in the first place. Overall, I don't think as urologists we comply particularly well. I spoke to David Etherington. He's a very well-established QC, criminal QC in London, been in practice for many, many years, has looked after many high-profile cases. And his quote was, anything outside the GMC guidance, as a minimum, would be courting trouble. This brings us to what David describes as the 6 guiding principles. Do not assume it will not happen to you. It may very well happen to you. Gone are the days where professionals were untouchable and such allegations did not come your way. And always remember that a small minority of professionals will deviate from the rules, will act inappropriately. So actually it's quite important that patients have a way of making claims, of things being escalated appropriately. Read the guidance, okay? And not just read the guidance, but I think perhaps there's a role during training to try and establish how trainees establish that, interpret that guidance. Because reading guidance is not quite enough. We all do induction, death by induction. Whenever we join a new trust, the trainees will be aware of that. You read it, but that doesn't really mean you know what to do when the fire happens and all the doors are shut and the lifts have stopped working. But you did the induction, so therefore you should do. It doesn't work that way. The third principle is the blush test, okay? If tomorrow you arrived in your office and such a complaint arrived on your desk, could you really go back and say, I wouldn't do anything differently? Would you do anything differently at all? And if you would, what would it be? And how might that change what you do next time? And that's a very important question to ask yourself. Think about it before, not after it happens. Can you rebut the allegation? And you can say, well, yes, of course I can. I've been in practice for X number of years. It's never happened to me before, and my patients think I'm fabulous. Of course I can rebut it. Well, can you, though? Again, this is something that you need to think about before, not after the allegation's made. What sort of evidence can you provide? Did you have a chaperone? Is their name in the notes? Does your chaperone actually know they were there to chaperone? Or do they think that they were in clinic for some other reason? You'd be amazed. You should be on guard. You should. And there's that old thing about intuition. When it just doesn't quite feel right, the patient walks through the door, you think it's all a bit strange, they're behaving a bit oddly, trust your intuition. Get someone else in clinic with you, get a chaperone in, and make sure that they understand why they're there. And I think the 6th is perhaps the most important. The best way to enforce ethical standards is peer group pressure. Okay? So there are several examples of this. But we can set a number of rules, we can tell people to do it, but unless we change the underlying culture that we live in, things won't change. And we will continue to take this as something not particularly important, but something that we should vaguely be aware of. It's irritating. You stand in clinic sometimes, you stand at the door, you're waiting for a chaperone, one doesn't arrive for about 5 minutes, you're running late, the patients are complaining, and you think, oh, you know, fine, it's just a quick examination, I'll get on with it. There is no doubt, speaking to Angus Thompson the other week, that the irritation and the disruption that might cost is a drop in the ocean compared to the potential implications of not complying with the rules. If any sort of allegation is actually proved, any kind of sexual impropriety, it could result in the end of your career, and in worst case scenario, in a criminal court, it could result in a substantial and immediate prison sentence. I'll end with this. when when life gets all a bit too much, it does sometimes as a trainee, doesn't it? And you drive to work in the morning. I like to listen to this song. You might remember this song, Baz Luhrmann, from a few years ago. And I particularly like this part of the song. Don't worry about the future, or know that worrying is as effective as trying to solve an algebra equation by chewing bubblegum. The real troubles in your life are the things that never crossed your worried mind, the kind that blindside you at 4 p.m. on some idle Sunday. I suggest that we make this something that crosses our mind fairly regularly to try and avoid it becoming a real trouble on our mind on an idle Tuesday. Thank you.
Hi, Beth. Thank you very much. We're going to take questions at the end of the session when we've got the whole panel together. Just as a show of hands in the audience, how many people regularly document with every patient that they see that they've offered a chaperone? Just as a show of hands. So less than 10% of the audience. How many people who do same-sex consultations feel as if they have to ask for a chaperone or consider it at the time? Even less. And just as a last show of hands, how many people have had a similar type scenario or heard of a colleague having a similar type of scenario as that chilling one you've just seen?
Okay.
Too many. Thanks.
Thank you very much. We'll just move on to our next speaker, Mr. Ian Pearce, consulting urologist just down the road at Manchester Royal Infirmary, probably now the head of urology. He's the editor of the JCU, and he's very active on social media, so you might see him on Tinder tonight. But he's going to give us a talk on consent photography and social media.
Thank you very much, Asif. Mr. Chairman, ladies and gentlemen, good afternoon. Unlike Vebev's talk, mine does have the infirmary there, MRI, as you can see. And you can see just there that the sky is still blue, just like it is outside. So, yes, you are missing out. But don't worry, the sun will shine tomorrow. I would, before I start, just like to congratulate Vebev on managing to use the phrase knee buckling orgasm, or leg buckling orgasm in a talk. I wonder whether she gave that sort of interview to a News of the World reporter and he was tempted to ask whether there was any other kind, which I imagine there is not. So I'm going to talk about consent, photography and social media. I've sort of expanded that slightly, not to just include photography, but also to include audio-visual, so video recording as well, which is becoming increasingly used, as anybody who's seen any of the sessions today will be able to say. So I'm going to talk a bit about consent related to those two media, and I'm also going to talk then about social media, because like it or not, social media is clearly here to stay, and you only have to log into Twitter to see that the traffic is quite enormous today, and I'm sure that will increase as time goes on. Now, everybody knows that consent, it's not a point in time, it's an entire process, and it begins with the GP allowing or seeking permission from the patient to have a referral up to secondary or tertiary care. When we discuss things with our patients in clinic, part of that is the process of informed consent. We are giving them the information that they can process and hopefully then arrive at a decision. From there, you might take consent in clinic. Can I just have a quick show of hands? Who takes consent in clinic as opposed to on the day of surgery? Who does it in clinic? There's quite a few. And who takes consent, the written consent, on the day of surgery? Okay, quite a lot. And I suspect if anything did happen and you were faced with a fairly decent QC, they might say, well, how can you take consent on the day of surgery? It is a process, but they've got to sign a form, haven't they? The patients come in starved, under duress, usually half naked, perhaps wearing one of those ineffectual hospital gowns. So it might not be that consent on the day, other than verification, is the appropriate way forward. So it's an entire process. And it won't surprise you to know that the GMC, this is why we pay our money to the GMC, have a good medical practice guide from 2013. I don't know if you can actually read that there, but this will outline the entire process for consent. And as everybody who teaches in medical school will understand, this is really all about the patient. It's us telling the patient, but more importantly than that, we've got to tell the patient in form and in a way that they can understand. The patient has to have capacity, and that capacity is specific to both time and to procedure. So, for example, you might be able to give permission, you might have capacity to have a blood test. You may not have the capacity to consent to a radical prostatectomy. Okay, they're different things, aren't they? So the patient has got to be able to understand the implications, not just of having the treatment or the investigation, but also the consequences and the implications of not having that intervention. They've got to be able to process and weigh that information up, and they've got to be able to decide upon a course of action. Okay, so it is a complicated situation that we often, I think, simplify just by merely putting down the complications on a form and getting the patient to sign. That's not the case. And I think we must also remember that consent can be withdrawn at any time. Okay, just because you consent in the clinic doesn't mean you will consent on the day. You may not even turn up on the day if our local population is anything to go by. The indications then for, and this again is from the GMC, for using audiovisual recordings can be fourfold. It could be routine part of care. There are a significant number of people who routinely video every one of their procedures. It may be important for pre and post comparison, and that's a fair indication. It may well be for research purposes, and again, that's a perfectly reasonable request and reason for performing, for recording anything that happens. It might be purely for teaching purposes. It might be for a publication in a book. But equally, it might be for broadcasting. And we mustn't forget that if there is broadcasting, there are other issues for consent, which we'll deal with in just a second. The consent you must get for recording must not only be from the patient, as we've talked about, but also from your employer, or from the person who is in control or in charge of the institution upon which you are doing the filming. This is usually either by medical illustration or perhaps from the Caldecott Guardian, which, as you know, will usually be your medical director or appointed representative. And if you are broadcasting, if you're doing things for television, whilst it may not be your responsibility to gain the patient consent, it is very clear from all of the guidelines, both from the GMC and Ofcom, that it is your responsibility to check that consent has been taken. It isn't good enough for somebody to say, oh yes, they've consented and it's perfectly okay. Now, in terms of photography, the standard consent form, lots of consent forms around the country, including my own, would have a little box, which I think you can just make out here, to say that publication could include an electronic form. And again, this is pretty widespread. It may well be that the policy in your trust is that medical illustration have to come and consent the patient. We have both. We are now no longer allowed to use our own photographic equipment. We have to get medical illustration up, and they create their own consent forms. So our patients usually sign 2 forms for any sort of recorded procedure. But there are pitfalls, aren't there? Don't use your telephone. Okay, the days of us going in clinic, and perhaps it never happened to other people, but the days of going into clinic and using your phone to take the photographs, they are well and truly gone. I imagine lots of people in the audience have children, is that right, with mobile phones? You can imagine my horror when I found out that my 13-year-old daughter was receiving my own text messages because our phones apparently were linked when we bought new ones. So there's nothing worse than your daughter saying, Daddy, I seem to be getting all your texts and all of your friends seem to be swearing a lot. What's going on? So don't use your own phone. Somebody else is bound to latch into it. Make sure that there are no hospital or NHS numbers around. It's very easy, particularly with x-rays. Okay, or for your screenshots from the electronic system. Make sure you can't see the face. I know these sound incredibly easy, but you'd be surprised how many people fall down on these things. Distinguishing features, and perhaps in andrology, they may be obvious, they may not be, I suppose. Depends on what an exhibitionist your patient is, I guess. Think about the dates. It may well be that actually each of these things appears to be fairly insignificant, but actually if you put them all together, you may have an element of breach of confidentiality. So all of these things are identifiers, and all of these things should be eliminated from any form of photographic record. Does anybody have Bailey and Love? You must have. This is taken straight from Bailey and Love, and as you can see, I think the standards for maintaining patient confidentiality are not fabulous, are they? I'm not sure that the cloth across his eyes is doing the job for me. But I suppose he does have other distinguishing features. They haven't even bothered to cover this guy's eyes. I don't know. Anybody recognise this? No? Okay. Pinocchio. These are not my hands, by the way. No gloves, I'm assuming they're the patient's. So all of these things, you probably say, well, you can't identify that, could you? You probably couldn't. There's loads of people hanging around with this sort of thing. So we've just got to be careful with the photographs. The videos, actually, they're almost a step up. The consent form is the same, really. The consent process is the same as photography. But the pitfalls are perhaps elevated simply because you've got an element of audio risk as well. Okay? And you get the summation of information, and that increases the risk. So you need to be extra vigilant with video recording. Now, the GMC, again, going back to their guidelines, they have very clear and defined principles, and I won't go through them all. You probably can read them, but essentially, it's all common sense. Okay? Don't do things that will identify you. Make sure you stop when the patient decides they want to stop, and remember that consent is a process and can be withdrawn. Okay? Social media then, moving on to social media, this is really just in memory of Tag Howard, and I'm sure that he would approve of this sort of, particularly the red box of narcissism for social media. We seem to follow everybody's life on social media, don't we? And it won't surprise you to know that there is a huge amount of guidance out there for professional use of social media. And that comes from pretty much everywhere you can imagine. It's a slight exaggeration to say that everybody creates guidelines, because of course if you go into most of the websites, they will direct you straight to the GMC. Okay, so although everyone claims to have guidance, the majority of them are a direct link, particularly the College of Surgeons, they go straight to the GMC. And amongst them, even if they are different, you get an element of commonality, and these are really warnings. The social media, without question, blurs any boundaries that may exist. And there is a real danger for professionals to have that boundary completely eliminated. So it's incredibly important that colleagues are appreciative of various things. And the first of these is the privacy settings. Oh, we set our privacy settings, only certain people can follow us, but actually lots of people can get around that. And no matter how good the privacy settings are, it's never truly private. And you have to keep that in mind when you engage in social media. And that brings us perhaps to point 3 of Webeb's talk, and that is the blush test. Would you do it again? Do you think you could have done things differently? It's a bit like sending an email in rage, isn't it? You always live to regret that. Think about your online image awareness, and not just from a personal perspective, but from your profession. We are all representative of a profession. And there is a danger of bringing that into disrepute if we forget that the things we post reflect on our image. And I think the other thing to remember is that this is a permanent record. If you post it on social media, you lose control of it, it becomes there permanently. You may be able to take them down, but they will reappear. The standards remain. The GMC is very clear about this. There is no question that the standards you would adhere to in normal practice also exist for social media. And you have to think about respect, not just for your patients, but for your colleagues and for the institution in which you work. The media is abound with stories of people who are disciplined, often sacked, for various infringements on various elements of disrespect. Maintain your boundaries, and this may even be maintaining separate profiles for your home and your professional life. As I said before, it's never truly private, it's never truly deleted. Okay? And keep an eye on for those identifiers, because there's a significant number of people out there who would happily engage in investigative behaviour in order to piece things together to find out and therefore breach confidentiality. So just to finish off then, really, the GMC principles are very clear. You need to have an indication for what you're doing, particularly if you're taking recordings. You need to be very careful to avoid any identifiers which may bring into the breach of confidentiality. When you're engaging in social media, particularly for posting of patient photographs and audio-visual recordings, think about the permanency. Okay? Think about the reach. This could go everywhere. It's never truly private. And remember the boundaries. So whenever you are taking photographs or audiovisual recordings, videos, make sure you have patient permission, written permission. Okay? And make sure it's very explicit that this may be for social media. It's very much like everything else, including chaperones, make sure it's documented very clearly in the notes. And I'll just leave you with one thought. I don't know if that comes out, but this perhaps will illustrate what Twitter's all about. Thank you.
Thank you very much. Just in the interest of time, I'm going to keep things moving, so no introduction necessary for the next speaker, a legend in his own right, Duncan Somerton.
Thanks very much indeed. Some great, difficult to follow such great talks as those. Anyway, we're going to talk about complaints today, and this is what we're going to do. We're going to talk about the extent of the problem, the potential consequences of a complaint or an escalation thereof, some suggested management techniques to how to get around them and how to avoid them in the first place. I'm going to give you a couple of examples of real complaints. As Vabe said, the number of NHS written complaints is increasing. It was 150,000 4 or 5 years ago. It's now 174,000. It equates to 3,300 written complaints in the UK per week, which is 500 a day almost, which is a lot. It's not just a problem with the NHS in the UK. It's a worldwide phenomenon. Belgium, Denmark, New Zealand and Australia and the USA have all reported similar increases in written complaints. Most of these complaints are about the medical profession, and they're most by patients and their relatives, but some are from colleagues and some are from trusts. And if you get a written complaint from a colleague or a trust, it's more likely to be investigated. There's no actual national data available on verbal or informal complaints. This is the sort of the tip of the iceberg. And I don't know about you, but our trust has got this brilliant system where if anybody rings up, the phone call is recorded, it's then put into text and then becomes a written complaint. So it makes your life even more administratively burdened. The complaints are mainly, about half of them, about sort of clinical issues. As Vabe said, about 12% of the attitude of staff, and all these here. You can see that even though we're only 5% of the medical register as surgeons, we account for 11% of the written complaints. So we do attract more complaints than our medical colleagues, or physician colleagues. In urology, we have about 1,400 people in the specialist register. We're the 18th largest speciality, so we do get a fair amount of complaints, but it's difficult to find out how many complaints we get, which I'll touch on later on. Is there a regional variation? If you live in the northeast, you're more likely to get complaints. Now, this has to be tempered with the fact that really we can't work out the data as to how many healthcare users or contacts there are. So it's just the number of complaints. It's very difficult to act as a denominator, to find the denominator. But obviously in the northeast and then London, patients seem to be more frequently complaining. If the complaint goes further, these are the reasons why people cite the requirement to take it further, and you can read those there. I tried to find out about urology complaints, so I emailed and had an email conversation with the NHS Health and Social Care Information Centre. They're very useful, but essentially it boils down to the fact that all written complaints are just grouped into 12 big divisions, and we're one of the divisions with all the general surgical specialities within it, so they can't drill down and find out the number of urology complaints, and they can't drill down beyond that to the number of genitourinary complaints. So essentially we anecdotally all think that andrology and GU surgery is more prone to litigation and complaints, which I think we all agree, but to try and actually find the evidence for that, it's very difficult. Julian may be able to tell you some more figures, but I don't think they're available in the public domain. In terms of surgery, it is an emotive subject. As Woody Allen once said, his brain was his second favourite organ, and certainly when you're dealing with male genitalia or even female genitalia, it's a tricky subject. And the counselling, as we heard, and the consent have to be done very carefully indeed. I think as you mature in your clinical career as well, one of the key parameters or key skills to develop is knowing when not to operate and when to actually, if the intuition tells you this patient is going to be potentially trouble and they have unrealistic expectations, is to have the courage to say, look, I don't think an operation is good for you. I'm not prepared to do that for you. You've got to keep careful records, and you've got to record erectile function and pre-op difficulties quite carefully. Stretched thoracic length as well as an indicator of erect length is sadly underutilised, and I think we're all guilty of that sometimes, thinking everything will be fine. It turns out not to be. You haven't written it down in the notes, and you're opening yourself to trouble. When I did quite a bit of general surgery before I did urology, and one of my bosses said this. He said, "Never operate on somebody you haven't at least said hello to beforehand." And I think it's a very good truism. You don't want to be meeting a patient for the first time when your registrars cancelled them and consented them. You've done the operation; it's gone wrong. You're meeting them in recovery or on the ward, and you're telling them that something's gone wrong. It's a very difficult place to be in. Obviously, you can't always do that. If it's an emergency case, you're called into the obstetric theatre, you can't avoid that. But try and get a dialogue or a relationship with the patient before you actually operate on them. So pointers. We know that these complaints arrive usually sort of on a Friday afternoon, just before you're going away for the weekend. It's a fact of life. Try not to take it personally. It's a process. Try and distance yourself from what's happening and say, okay, it's part of my job. They're bound to happen. They do happen. I'll try not to worry about it. But nonetheless, they are a source of worry and anxiety, and it's a lot of paperwork as well. The most difficult ones as well, I think the transition from a trainee to a consultant also, is the fact that as a trainee, if you do something wrong, you get shouted at for it. As a consultant, somebody else can do something wrong on your behalf, and you'll get shouted at it. You get shouted about it as well. So it's very difficult. And the trust will probably keep a league table of how many complaints you've had as well. So, and how they interpret that is yet to be seen. But be careful of that. And obviously, these complaints can get worse and worse if you don't head them off. So how can you deal with them? Well, actually, sometimes complaints can be good. I mean, that sounds a bit strange, but actually, in the true nature of reflection, you can look at your practice and say, okay, should I have done something different? Could I have avoided this? You can change your practice as a result of it, or you can use it to say to your trust, this happened because we haven't got such and such, we haven't got chaperones in clinic, we need chaperones in clinic, we need more resources. This will help us to be better in the future. So they can be positive things, but often not. And also, I think, keep it in proportion as well, because in your dark days, it's quite nice to have for your revalidation and appraisal a big box or a file or electronic record of all the thank you letters you've got over the years and all the people who've been happy, and just read those when you're feeling a bit under duress and being battered by all these complaints. Also, if you do get complaints, it's good practice to put them into your appraisal discussion and revalidation so that you're not accused then of ignoring them and keeping them hidden. It's a very good thing to bring them up and air them in your appraisal. I think if a patient takes the trouble to write a long letter of complaint, they're expecting a reasonably prompt response. But what they don't want is a quick letter dictated the day afterwards because you're angry and upset, and you send something that you might regret afterwards. So I would say obtain all the facts, take the time to obtain all the facts, but actually be mindful of the time ticking away, and the patient wants that response. Often it's gone through the trust, so there's always been a bit of a delay before you get the complaint, so you just must be aware of that as well. Also, sometimes the trust will tell you that the patient's complained about something, but the details of what they're complaining about is a bit sort of obscure. So get the original complaint letter from the patient, even if you're only mentioned tangentially, just to see exactly what you're supposed to have done or not done. And then if the solicitor's involved, get a letter from those as well to see what their view is as why you have failed in their eyes. And I think the point is, address the issues sensibly, logically, one by one, no matter how spurious, and take it seriously. I find it helps to actually sit at a quiet time in the office, not in the middle of the busy working day, but perhaps at the end of the day, and just construct a timeline, either on a computer digitally or written. Just write out what actually happened, go through the notes, get all the pieces of information, just to get it in your head. Because sometimes you find that you assume A happened before B, before C, but in actual fact, looking through the notes, B happened before A, and then C came around at the same time. So just have a look at that. And work within your trust mechanism. Don't stray outside that. If there's a well-worn path that you're supposed to follow, do follow it, and don't tend to write a letter to a patient telling them exactly what you think of them and not to bother you, etc. If you can head things off, a letter straight to the patient, telephone call, email, or face-to-face consultation often gets you out of trouble. And if it's going to be a bit sticky, it's nice to have a witness there as well. In fact, I think it's essential to have a witness. And I find that if you tailor your response to the level of the patient's understanding or express concerns, that's very important indeed. Try not to bamboozle them. Once you've had that meeting or they've sent the letter, record it and make sure it's very clear. I've been in consultations with angry patients who've insisted that they had an audio recording, so we did that at their request, and halfway through they just started swearing and stormed out and slammed doors, and it was a brilliant piece of information on our part, actually. There's lots of people around, if you get a complaint, that can give you advice. Colleagues, mentors, medical defence unions, everybody. So if you feel that you want to get some advice, go and do so and use it. And sometimes complaints are easy and reasonable to address. These are a few. There's 2 complaints I'll show you examples of. This was somebody for Peyronie's surgery, came to talk to us about Peyronie's surgery. And you can see in the letter the clues are: he's worried, he's unsure, he wishes clarification. He felt rushed during the consultation. It was a very long consultation, but he felt rushed during the consultation. He's worried and he wants clarity. It's not an unreasonable letter. It's just, dear doctor, I'm not quite sure what we said. I'd like to go. This was written before he actually had the record of consultation, which is sent out automatically. But he went home that day, wrote the letter, and then we had to answer it. So this is how I answered it. First of all, I said, I'm sorry. Yep, you're quite right. I'll address your points in order. There's no indication, reasonable. The patient was obviously quite intelligent, used quite a well-structured letter, so reply in an adult and sensible fashion, and just basically saying, look, I understand you're worried, don't worry about it, this is why we discussed it, I hope that helps. 2 weeks later, nice letter saying, thank you very much, I'm sorted out, I understand now, it's been a great help. That was one of the nicer ones. And you can put this in your appraisal folder, and it's where you've turned a complaint round to a positive outcome, and it's something to discuss with your appraiser. This is a slightly different one, but a complaint from primary care. As a young patient, this 23-year-old, admitted with a 5-day history of severe left testicular pain. It had got better by the time he got to hospital. The FY1 wrote the electronic discharge summary saying that the diagnosis was a missed torsion, dead testis, sent out. The GP then wrote to me. I think there was a bit more to the story, in as much as the GP had seen the patient a few days previously, but he felt that the diagnosis and the stark fact of the letter was a bit harsh, which I could sort of see his point, I suppose. He had made a clinical error, he knew that, but he just didn't like the terminology and the wording of the discharge summary. So this is the letter we got, and then saying also that, you know, look, we have enough trouble in the healthcare business as it is, why are you making my life a bit more miserable? Which is fair enough. So we sent a letter back, just swallowed our pride and said, look, you know, this guy's really nice. He wants to be a general practitioner. He didn't mean any offence. He's an FY1. You know, yes, we recognise that there is a terrible environment we work in, and sorry about it, basically. The point was that he did miss the diagnosis, but we sort of glossed over that in the letter. So in conclusion, I think it's an emotive area, it's complex. I think you need to select your cases carefully, you need to counsel well, and you need to consent properly. I think in terms of consenting, I actually do somewhere in between. I don't consent them in clinic, but in the clinic letter I write out all the possible complications, send a copy to the patient and the GP, and then I do the consent on the day of the operation as well. So it's sort of belt and braces. They're becoming increasingly common, these complaints, so you need to handle them carefully. You need to be honest about it. If you had made a mistake, put your hand up, say, I'm really sorry, don't try and wriggle your way out of it, just be honest, duty of candour and all that. And if you are out of your depth and you feel that you need a bit of advice, seek advice, because I think we've all been through it and we all know what it's like, and we'll quite happily give advice on similar cases. I think keep in perspective, for all the complaint letters you get, there are many more patients you've seen who haven't complained, and are quite happy that you've done a reasonable job. Thank you.
Thank you very much, Duncan. So I'm going to call on our final speaker for this session. Julian Shaw, who's just taken time out from playing the guitar, and he's got a huge experience of medical legal reports and going to court, and he's going to round up with genital youthful surgery and the law. We've got to be out by about 5 for the satellite session, so this will be our last session. Thanks.
Thank you very much, ladies and gentlemen. It's always interesting when you're introduced as an experienced doctor, which usually means you're very old. Yes, medical legal work, I do much of it and still do clinical work, and I think medical legal work teaches you much about patient management and how to get out of trouble. I hope that we can help you. I think this session has been excellent. I've learned something. If you're not scared now, then you jolly well ought to be. Yes, people make complaints, and it's important to try to avoid getting into trouble, but it's unavoidable that you will get into trouble. I've had a letter from a patient saying, I'm referring you to the GMC. I never treated her. I did a medical expert report saying she didn't have a case. That was 2 years ago, so I'm waiting to see the outcome. So even when you don't even treat a patient, you can find yourself in difficulty. A few little introductory things, because obviously you want to see some pictures or discussion about how to manage GU cases, but let's think about it. Surgery is difficult to learn, isn't it? It takes a lot of training and experience, and I think the trouble with the modern surgical training is it doesn't give you as much as you perhaps would have done in my day. So 40 years ago, things were different. We got away with it in the sense that we were allowed to do pretty well anything, mostly unsupervised, but we did get a lot of experience in doing so. But patients perhaps suffered more than they would do now, where you have more supervision, or maybe not, I don't know. We can discuss that. You can never get enough training. So the more you do, the better you get, especially if it's supervised. But you also need to have unsupervised training too. I'm sure you agree with that. But you must realize your own limitations, And if you have any sense, you should log not only the cases you do, but the outcome of those cases. And so when a patient comes for surgery, if it was you having an operation, what would you expect? You want the best outcome. You want it to be done by the best surgeon. You don't want it to be done by a trainee. And the first rule is never say, well, that's the first one I've done. Yes? So you may never have done it before, but if you're going to do it to the best of your ability, usually with supervision. And the one thing that really distresses me when I see medical legal cases is that people step beyond their abilities when easily you can phone somebody up. You're only a phone call away from any expert in the world. I've talked to Tom Liu on the phone in America when I was dealing with a Peyronie's case, if I needed to. You can do the same. You could speak to Chris Chappell, you could speak to me about anything. It will be very useful to do that. It could get you out of trouble. I know that Ian talked about consent, but nowadays consent has to be more explicit and extensive than ever before. You can't just write operation signed, which is what we used to do 40 years ago. Even if complications are rare, they need to be recorded. So even if it's a 1% complication, or for instance with vasectomy, as I'll talk about later, it's 1 in 2,000, you have to write down recanalization rates. So consent can be very critically appraised in a court of law if it's not been properly recorded. And a lot has changed since this particular case of Montgomery in 2014, where in the Supreme Court it stated an adult person of sound mind is entitled to decide which, if any, of the available forms of treatment to undergo, and his consent must be obtained before treatment. However, a patient has the right to advise a doctor he or she does not wish to know about the risks, but he must not withhold information about that. Let's deal with some specific conditions which affect you as andrologists, and the commonest perhaps is vasectomy. The thing that disturbs me about vasectomy is that it's often done in general practice, isn't it? Not by surgeons. So patients are being treated without necessarily going to surgeons who are experienced or trained in the procedure. And of course, you will consent about recanalization. It's well known. 1 in 2,000 cases will recanalize, often early, and that's why you do sperm counts. So you warn your patient. But it's not the same as missing the vas. If you do not find the vas, then that's a failure of the procedure. And I think it's quite useful to send the vas off to the lab to make sure that is what you removed. If the patient develops a hematoma, they're usually very upset. And therefore, you need to treat that patient, but should you immediately drain that? I've had this discussion with other surgical experts, and some say, well, if you get a hematoma, it's best to leave it and let it resolve in its own right, which it will, which does reduce the risk of infection, but it depends when it presents, and if it's acute, it's probably best to drain. One of the biggest bugbears that we face is torsion. And I'm sure, as all of you will have had training in this field, you will know about torsion. But it's common enough to be a serious problem, but it's often delegated to the most junior member of the team. GPs make the diagnosis late, hospital doctors make the diagnosis late, as you saw previously presented. Often the patients will present late. But don't forget that within 6 hours the testicle may be dead, and that patient will be distressed as a consequence of testicular loss. Now, there are a lot of discussions, particularly in our trust, where we're moving over now from UCLH to the National Heart Hospital, where we don't have emergencies, they're all at UCLH. Will the general surgeons do the torsions? Should they be required to do them? I don't think so. I think torsions should be done by urologists who are experienced in treating torsion. Is it a very simple operation? Well, it's relatively simple. And if the patient presents and there's any doubt, operate upon it. It's far better to do that within a very short time frame. If you can scan them, but if it's not in the day, you can't operate upon them. But I believe that all trainees should be able to operate upon a torsion. Can anybody here operate on a torsion confidently? Well, I've been in at night helping trainees who can't operate on torsion. To me, that is bizarre. It should not be the case. We must be able to train all our trainees to be able to do a torsion with confidence and to fix the other side. Scrotal surgery is easy, isn't it? Well, not really. Scrotal surgery can be very difficult. The scrotum is a difficult organ to operate upon. It bleeds. It's quite difficult sometimes to find the layers. And the biggest risks are bleeding and infection. And the last thing you want to do is to lose a testicle. Failure to resolve the problem when you're operating can be very difficult for you, but it's worse for the patient. And the patient has great expectations of the outcome for something that you said, it's a simple operation, you'll only be in a day or overnight. If a patient loses the testicle, although you may write that down as there is a 1% risk of testicular loss, that doesn't mean to say it's not negligent. The fact that you mention a complication doesn't mean to say it's negligent when that complication occurs. A bit like when a gynecologist says ureteric injury is a complication. Almost invariably, if you injure a ureter and it is unrecognized, you will be sued and the patient will win from a gynecological point of view. So if you're doing a varicocele ligation and you damage the vessels, damage the artery, and the patient loses the testicle, that generally will be negligent. If you do a hernia repair and the testicle is injured, that will be negligent. If you do some damage with undescended testicles, which has come out of your experience, then you will be negligent. One thing that's come up recently is with regard to the management of testicular cancers. Treating the simple, straightforward testicular cancer proven on a scan in which you've done an orchidectomy is never usually a problem, provided you have considered sperm banking in the patient who is fertile. But if you come across a lesion that's benign within the testicle, and there is question on the scan that it probably is benign, should you remove the testicle or should you do an intratesticular exploration, removal and a frozen section? Patients don't want to lose their testicles. So even though you may justify to yourself, well, it was probably a cancer, I took it off, it was the right thing to do, I've seen experts that argue that you should have preserved the testicle and not removed it. So be very careful when you come across what could be a benign lump. As you stated earlier on, Duncan, that the male genitalia are the most important organs in our bodies, aren't they? Yes, especially our penis. So the last thing we want to do is to go and have something done to the penis and come out with an unsatisfactory outcome. And circumcision probably is the most badly performed operation. It's often delegated to junior doctors. If you look at this picture, you can see somebody has marked up the site at which that circumcision is to take place. Is that in the right place? Certainly not. That is far too low down. That will cause significant loss of skin. And if you pull the foreskin up and chop it off where you think the glans is, you will shorten the skin, you will cause problems with erection and pain and cosmetic results, and if you're sued, you will absolutely lose. I would be very critical of a circumcision that was like that. So be very careful when you're doing circumcisions. It's far better to leave more skin than leave less skin. You can always revise it. So it's badly performed, too much skin is taken off, or too little skin is less of a problem, especially if you explain it to the patient. You shouldn't really get infection. Pain can, of course, occur, but the cosmetic appearance is critical. You need to do the operation with consideration and care and get an excellent outcome. Of course, prevent bleeding so the patient doesn't have to go back, but sometimes you can see Fournier's gangrene after circumcision, but be careful and be on top of it. So you don't want to have a vascular necrosis of the penis, which can occur especially in children. You've had a lot of discussion about Peyronie's disease today, and of course it's a distressing condition, especially when the penis is very bent. And if you're going to straighten the penis, of course the issue of discussion of outcomes occurred earlier in the day, but certainly don't overdo it. If you overcorrect the penis and the penis goes from being bent upwards to being bent downwards, the patient will be very unhappy. And I've got one case going on in which that has happened. You've got to warn of the risk of ED, and of course, no operation is perfect. And I note you discussed very much earlier on in the relationship to consent and photography, then it's very important to get the patient's permission to take photographs, particularly intraoperative photographs showing that you corrected the abnormality, because you can show, we did it, it was a good outcome, this is what it was like. So if it does change in the post-op period due to scarring, it's not necessarily due to a fault in the surgery, it's the patient's healing that was the issue. Penile implants are particularly troublesome. They're difficult to put in. If you do them all the time, it's probably easier, but if you don't do them so often, they can be very tricky. And if a patient gets a complication of a penile implant, they're very, very unhappy, because the outcome can be no erection. You had no erection before, you had expectations and no erection afterwards, and it will be worse. So if you get injuries during the surgery, tell your patient about them. Fix them if you can. If you stick a needle through the implant, is that negligent? It will be if you don't recognize it and the patient comes back and the device hasn't worked, and you then have to revise it or take it away. So, and if the bits come out at the end, then is that due to negligence or not? Well, it may be. It depends upon the length of the implant relative to the penis. You discussed priapism earlier, and there are a number of cases going on of priapism in which it was either neglected or badly managed, and I think it is often badly managed, and it should be referred to centres, or if in doubt, ring a centre like UCLH where they have a lot of experience. One final thing I wanted to mention was the issue of catheter balloon trauma, and it's not usually something that is in the province of a doctor, but usually in the province of the nurses. If a catheter is taken out with a balloon partly inflated, it will damage the urethra. When a catheter is taken out from a patient who's had a catheterization for whatever reason, it's usually not painful. There might be a little bit of a as it comes out, but it's not painful and there should be no bleeding. So imagine if you pull a catheter out with a balloon inflated, which I've seen on a number of occasions in medical negligence, there will be pain, bleeding, and the patient will usually get a stricture. That is negligent. It should not happen. And I think it's very important when you put catheters in to write in the notes 14 French catheter, 10 mils in the balloon. That means that the nurse will know that 10 mils have got to come out when the balloon is deflated. So it's usually associated with legal attention. We all want to avoid being sued. Being a medical expert, of which I do a lot, we are not partisan. We are supposed to be considering a case in order to present it in a court of law. That means if I criticize somebody and I go to a court of law and I'm made to be an idiot because I made a wrong decision, how do you think it would feel for me as an expert? When we do expert work, it's to try to help the courts. People make mistakes, they do things that are not good, and therefore somebody is going to be critical of you. It's better that it's done in medical negligence than it is in the GMC. That is far worse, because that can affect your career. Being sued for medical negligence doesn't mean you go to the GMC. To avoid being sued, as you described earlier on, be careful and compassionate. Be open with your patient. Give them the best care you possibly can at the highest standard. If you get complications, make sure you manage them properly. Be kind to the patient. Say, look, I can't fix it, but I know somebody who can. And that's very beneficial to the patient, and be involved with that care. And keep extensive and contemporaneous records. That's very important. I sit on an audit committee in a private hospital, and I can tell you 70% of consultants don't write in the notes. That is bad medical practice. To persuade them to do so is very difficult, but that's wrong. And the most important thing is never falsify the records. If you have to write something in after the event, write it in, date it, time it, and put it in. It's fine. You can write down, by the way, I forgot to write this down, and here it is. If you maintain the highest level of medical practice, it still won't keep you out of trouble occasionally. I was told the other day by the NPS when I rang up about this woman who's complained about me, he said, there are 10,000 doctors referred to the GMC each year. 10,000. 10,000. That means that you have the likelihood of being referred to the GMC at least 3 times in your lifetime. And that's not even doing anything wrong necessarily. Thank you very much.
I'm just conscious of the satellite session about to start, but is there any burning question for the panel just before we round up the Andrology Day? I've
got a quick question for Ian. You know, you were talking about consent for audiovisual. That's taking the patient's consent for using their images when you're doing the operation. But what do you do with a patient who comes into the clinic room and puts their iPhone down on the table and says, I'm going to record the consultation?
Yeah, there are fairly clear guidelines on this. That's actually recording is perfectly okay. They have to inform you, of course, and you are it's perfectly legitimate to request a copy of that recording. And equally, particularly for things like complaint resolution, what will often happen is that you'll come in with your PALS person, meet the family, and they will record that conversation too and offer transcripts to both parties. So I think that's perfectly reasonable, and probably more and more, actually.
Okay, thank you very much. So we'll round up the day. It's been a fantastic Andrology Day. I'd like to thank all the speakers, everyone that's chaired the sessions, and thank you for coming along. All of those going to the velodrome, just make sure that you wear a helmet. All of those at the five-a-side, enjoy the evening. It'll be a fantastic evening. Let's raise loads of money. Thank you very much.
And if you're not going, just play with the helmet.